Hello, everyone. Welcome, welcome. I'm going to give people a few more minutes to log in and then we can get started. In the meantime, feel free to use the chat and say hello and check that you can access the chat because I will post some links that will be relevant to you, especially those of you who are collecting a CEU or an APD, as I think we now call them in the UK, based on the UK Society's planning. Say where you're from as well. I wonder if I only have UK folks today or if I've got anybody from outside the UK joining us. I can see some familiar names. Hello to you guys. Oh, hello from Glasgow. Hi, Nadia. You don't count as an external though, Nadia. You're one of us. It doesn't matter if you're in Glasgow, you know. You're part of the fam. Hello from Cali. Oh, my. I see London. I see Ireland. I see Halifax. Oh, Essex, Cornwall. All right. From all over the world. Good, 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 good. So let's get started. And hopefully by the end of my intro, more people will have joined. For those of you that don't know me, I'm Thanos Bostanis. I am a lecturer at the Tizard Center at the University of Kent, and I'm also the director of the MSc in Applied Behavior Analysis and Positive Behavior Support. That MSc has a campus-based and a distance learning version, and we live at a day and age where we have multiple accreditations and verifications to take into account. So we meet BACB criteria, we meet UKSBA criteria, we meet IBA criteria. Soon enough, I think it's going to take me 10 minutes to say all the acronyms if we keep doing this as a field. We also have a peer-reviewed journal. It's called the TIZARD Learning Disability Review, and we always encourage practitioners to submit their work. It's indexed, it has a small impact factor, it's behavior analytic friendly, and it focuses on learning disabilities, or as we call them internationally, intellectual disabilities. There is a slight variation in terms in the UK and across the globe. So as part of our work of disseminating good practice in ABA and PBS, we invite esteemed colleagues of ours, like Dr. Cody Morris, that is going to present to us today, and they take some time to talk about their impactful work and help us think more about how we can improve our practice. So, Cody, thank you again for joining us today. Please take it away. I'll be in the background. Folks, keep an eye out for the 3 keywords I'm going to mention, and I will post some links that you will need in the chat, so make sure you can access the chat. Cody, you're up. Thank you.
Thank you. Well, and thank you all for coming to the presentation, giving me the opportunity to talk about something I'm really passionate about, which is ultimately client involvement in therapeutic decisions. So thank you to the team that's putting on this event. Thank you to Thanos for inviting me to present. A little about myself. So I'm a professor and researcher at Salve Regina University in historic Newport, Rhode Island in the United States. And at Salve, my research is focused on improving behavior analytic practices, which we embody in a few different ways. We look at assessment and intervention strategies for challenging behavior. We look at organizational practices, and we also look at this concept of client involvement in therapeutic decisions and how to help establish and support that in any given therapeutic context. Another role I have at Salve Regina University, which is going to be coloring some of my presentation, is that I'm the chair of the IRB, or like the research review board that looks at ethical research practices across the university. And so, because I've had to be trained in ethical research practices, a lot of the information I pull from things or to things like consent and assent, I'm bringing through that ethical research paradigm, as well as my role as a behavior analysis researcher, as well as a clinician. And so I'm kind of wearing multiple hats when I'm thinking about this topic. And I think that will be kind of clear as I get into the topic and talk about some of these nuances. My interest in the idea of assent started when I was in graduate school. One of my very first clinical experiences within grad school was going to what was called a treatment team meeting for an adult who had intellectual disabilities that I was serving. This individual lived in a group home, highly supportive group home, had very, very limited communication, and they had a court appointed guardian, so they weren't their own guardian. So one of my very first times meeting them, I was asked to go to this treatment team meeting at their group home. Went out to the home. The social worker was leading a meeting where she was going over like a packet that was the treatment plan. So it included everything, their psychiatric services, the group home services, like a huge, huge packet that kind of covers everything that this individual is going to kind of be experiencing throughout the year, including the behavior analysis stuff. But the social worker pulls out this packet and she begins describing the treatment in about 3 minutes, which couldn't possibly have summarized everything in that packet. The client sat there the entire time. When the social worker wrapped up what she was describing, she said, "Okay, the guardian who's not here has already signed consent, so we just need the client to sign their assent." They slid the packet of paper over to the client, who kind of scribbled on the signature line. The social worker pulled the packet away. The client actually then just started scribbling on any piece of paper that was near them. Social worker said, "Oh, cool. Okay, cool. We've got consent, we've got assent, and we're good to move on." And seeing that process, seeing how little to essentially no interaction or feedback the client was actually permitted to give in that process, I thought there has to be a better way of doing it. There has to be a much more involvement from clients in therapeutic decisions. And so I started doing some research on that topic. And that kind of led me to publishing on the topic of assent and some related concepts, and focusing a lot of my research on this topic. The purpose of the talk today is to further advance the conceptualization and understanding of assent as it relates to involving clients in therapeutic decisions as an overall category. And so as we get started in that topic, I want to start by talking about client involvement in therapeutic decisions and how important that is in any treatment period, and any services being provided to the folks that are considered vulnerable, folks that aren't considered vulnerable. It's important to involve them in therapeutic decisions. And behavior analysis, in particular, has a rich history of considering this and trying to involve this as much as possible. And so when you look back at the history of applied behavior analysis, you can see very prominent behavior analytic researchers grappling with how to further or maximally support client-centered practices and ultimately client involvement in therapeutic decisions. So starting with B.F. Skinner, even before the concept of applied behavior analysis was a thing, he was talking about power differentials and counter control in the context of treating individuals with intellectual disabilities, and ultimately advocated, hey, we need to be able to establish counter control measures or other strategies to make sure that the client's perspective is known, understood, and protected in therapeutic context. Then with the creation of applied behavior analysis by Bayer, Wolf, and Risley, when they described really what applied behavior analysis was, they very clearly specified the importance of social significance in services and in research, which then had impacts on the importance of understanding the client's perspective and making sure that whatever services were being provided were being delivered to the individual with the goal of improving or helping the client improve the quality of their life. Then there was a follow-up paper by one of those authors, Montrose Wolf, who further elaborated the idea of social validity, talking about how to specifically measure social validity so that we could understand the perspective of the people being impacted by the services. And then Diane Bannerman and colleagues writing a famous paper in 1990 that was focused on helping clients have more direct involvement in service decisions. And so I bring this up as context for this discussion because it's important to understand the history, understand that the topic of assent and client involvement in therapeutic decisions is not new at all. There's a very rich history of this in behavior analysis. And certainly some of the specific practices of behavior analysis have not been great in this area in some individual context. However, I think you can see when you look at the history that really this goal of getting clients involved with therapeutic decisions has always been at the heart of what it means to provide applied behavior analysis. In terms of seeking this client-centered approach to treatment, there are a few things to consider, right? If we think about how we're going to, as a field, provide client-centered practices, you have to think about how you utilize empirically supported practices. So, looking at published research, looking at data. You have to consider relevant ethical guidelines and principles, right? We have our ethics codes. And then you have to be able to understand the client's perspective. And that piece in particular is what I'm mostly interested in and, what we're going to be talking about today. So in terms of understanding client's perspective, there's a few sort of important skills that need to be considered. One is the practitioner skills and attitude. So there's a lot of work in behavior analysis focused on specific paradigms of thinking about clinical context to help practitioners build skills and attitudes that would help them understand clients' perspectives. Things like humble behaviorism, compassionate care, cultural responsiveness, and there are many, many more. In terms of getting client involved in therapeutic decisions to help understand their perspective, there are a lot of individual strategies to help do so. There's a lot of research in our field on the concept of social validity and how to achieve social validity and measure social validity. There's research, of course, on assent and consent. There's research on treatment planning. So this the idea of coming up with the overall treatment plan and how clients might be involved in that process. There's choice within treatment. So how individual clients are making choices in the context of treatment or about treatment, moment to moment. There's indicating responses, which is ultimately, it's different signs that a client is initiating certain or interested in certain things. And then there's indices of happiness, right? Indications that the client is happy and satisfied. And so when we look at this overall wheel, as I like to think of it, you can see there's a lot of specific strategies and how to involve clients in therapeutic decisions. All of these strategies have individual nuances and require sort of careful planning. And so I'm going to focus most of this talk on assent and consent in particular as a way to illustrate how complex each of these are and sort of as a way to model some of the considerations that are important with each one. And so I want to start this conversation off by defining assent, make sure we're on the same page about what it means to provide assent. And to define assent, it's important to define consent because most of us are relatively familiar with the idea of consent. It's something we've commonly experienced ourselves in most situations. And so I want to define assent to start this off. So consent is often defined as a person who is legally authorized, so they have some legal status, giving permission for themselves or another individual to participate in a procedure. So when an individual is the legal guardian of someone, they can provide consent for someone else. After they've received adequate information about a procedure. So there's this informed piece within consent, right? They have to know what they're agreeing to do, right? So after they've received adequate information, with the expectation that they could withdraw their consent at any time. So consent is not permanent. Consent has to be able to be withdrawn. In contrast, the definition of assent is very, very similar, but there are a few important distinctions. So assent is typically defined as a person who cannot legally provide consent for themselves. So this is an individual who is not their own legal guardian for whatever reason. Could be that they are underage, could be that they are considered a vulnerable population, perhaps they have significant intellectual disabilities, and for whatever reason are not legally considered their own guardian, indicating their willingness to participate in a procedure via a choice. So they're given some choice to participate or not after they've received adequate information about the procedure. So just like consent, there needs to be this informed piece, right? If you're asking someone to participate in something to get their assent, it's very important they understand what they are agreeing to do. And just like consent, it is done with the expectation that the individual can withdraw their assent at any time during the procedure. Just like consent, assent is not a permanent fixed decision. It's important they be able to withdraw it. So, in summary, assent specifically pertains to clients affirming their willingness to participate in procedures. It does not represent the entire wheel, right? Each of these is distinct and has its own like procedures, its own strategies, its own outcomes. And assent is one specific part of how you might involve clients in therapeutic decisions as it relates to them affirming their willingness to participate in those procedures. When dialing into assent, there's some important considerations. I have 6 listed here that I will talk about today, but this isn't necessarily an exhaustive list. The first consideration I'll talk about is determining the applicability of assent. So trying to understand when assent is relevant in a clinical situation. If you look at the ethics code for behavior analyst, as maybe a starting point to understanding when assent should be solicited. It says behavior analysts are responsible for obtaining assent from clients when, quote, applicable, or research participants when, quote, relevant. So really this is saying we should be considering getting assent, but it's not exactly clear as to what circumstances we should and shouldn't. If you look at the core ethics principles of the code, which I love, it specifies that behavior analysts must treat others with compassion, dignity, and respect, and explicitly calls for promoting self-determination and personal choice in therapeutic context. And I think when you see that core ethics principle and you look at the wording they have listed as applicable and relevant, really to me what that means is assent should be solicited as much as possible. Right, so the goal here when we're trying to determine is it applicable, is it not applicable, it's really doing so with the goal of doing it as much as possible. When you look at other guidelines, so like here in the US, we have the Federal Policy for the Protection of Human Subjects as an example, which is the federal rules that all researchers have to follow. It describes constructs like capability, and this is true for other ethics codes that I've seen. They'll say that assent should be solicited when an individual is capable of it or something else like that. But that construct is very complicated and frankly problematic for several reasons that I won't go into all the details of. But really, it's a imprecise way of potentially ruling out a lot of people who could very well meaningfully engage in therapeutic decisions. And so the idea of having like a capability requirement, I think, is problematic. And so when we think about these ethical obligations, it seems evident that assent is important from an ethical perspective. However, there might be some ambiguity as to when it should be done. And so some considerations for making decisions about assent, it's important to understand the therapeutic benefit of assent. So arranging assent has the potential to help produce therapeutic benefits. It also potentially has the risk of producing counter-therapeutic benefits. So we need to understand both sides of that. In terms of therapeutic benefits, it's important to understand that assent gives clients an opportunity to exhibit and practice self-determination and personal choice, which, in my opinion, is the entire purpose of providing behavior analytic services, right? It's to help clients gain as much independence and autonomy as possible, and being involved in the therapeutic decision gives individuals the opportunity to actually practice and demonstrate independence and autonomy. It also provides clinically relevant information to behavior analysts. Understanding what a client wants to do, doesn't want to do, is obviously an essential component of designing interventions. And so we need to, consider assent for that purpose as well. And then another benefit is that, as we've been talking about, assent is one component of involving clients in therapeutic decisions. And so it can ultimately help us achieve better client-centered services when we're getting them involved through assent practices. There are some potential risks of assent, though. In particular, there's a risk that assent may not be appropriate and could cause treatment interference and/or damage rapport in certain contexts. In particular, when you're implementing what are often referred to as necessary procedures. So situations where a client has to be exposed to something, sort of regardless of whether even you want to do it or not, it is something that has to be done. For example, I work with a lot of clients, young children, who have to take life-saving seizure medication. They have a significant seizure disorder, there's a medication to treat it, and if they don't take their medicine, they're at risk of death. It's not my decision whether they take the medicine or not. I'm not a neurologist, I'm not a medical doctor. I wouldn't know the first thing about prescribing or requiring medication. That's not my job. However, the client's medical team and family are saying that this is absolutely necessary. And even if the kid doesn't love taking the pills, I have to work with the individual, the child, to take those pills. In the same way that a child probably isn't opting into getting their blood drawn or getting shots, but might need to ultimately, for their own medical safety and well-being. In those situations, assent may not be appropriate, right? Saying, hey, do you want to take a pill that they're going to have to take regardless? It's not going to be appropriate. And then also there can be disparities in client preference and treatment effectiveness. So sometimes a client may want to engage in a treatment that is potentially less effective than alternative available treatments. And in those situations, when the client wants something that is less effective than what else is available, there has to be some consideration made. So some of those sort of general recommendations to navigate those sticky areas is, again, going into any context with the understanding that assent should be solicited as much as possible. That a client's choice to assent or not should carry weight in the therapeutic decision, and consider consulting a client's stakeholders to ensure that they account for all relevant variables. So when you're making these decisions about, should I prioritize treatment effectiveness over preference? How do I navigate these necessary procedures? Those shouldn't be an individual decision. That should be the entire treatment team involved, including the client as much as possible, but ultimately making the decision that the sort of community of the team is ultimately supporting.
Cody,
It's important.
can I jump in? Sorry to interrupt, just for the first
Go ahead.
keyword. Guys, the first keyword is benefit. The first keyword for those of you collecting CEUs, APDs, and so on is benefit. Thank you.
The next consideration is when assent cannot be prioritized for whatever reason, it's understanding the strategies to solicit it as much as possible, to communicate why it's not being prioritized, if it's not being prioritized, and seeking the client's input on other components of the necessary procedures. For example, when I work with individuals who have seizure disorders and have to take life-saving medication, I will work with the treatment team to determine how much flexibility is in the routine of taking the medicine. Can the client choose which time of day they take the medication? Sometimes they can't. Sometimes medical doctors say it has to be taken at noon, after lunch, whatever. Okay. Given the parameters that I have, where's the flexibility and how can I create as much choice within this arrangement as possible? Yes, they have to take the pill. Can they choose what they take it with? Can they choose what context they take it in? Can they choose who gives them the pill? Create as much choice as possible within that decision. That doesn't equate to assent. However, it is maximizing their independence and autonomy as much as possible given the context. The next consideration is assessing assent-related skills. Behavior analysts have this amazing opportunity and privilege to work with a very diverse array of clients who bring a very diverse array of skills to the table. And that's an amazing privilege that we have to get to work with individuals that have such varying skills and interests and backgrounds. And with it comes the importance of understanding how to take an individual as an individual and create a therapeutic context that is maximally supportive to them. Part of that process is matching skills and assent procedures. So when thinking about what skills are relevant, I want to understand the different assent procedures and the skills that would go along with those, and how I might look for specific prerequisites for my clients so that I can maximize assent opportunities. So client skills related to assent procedures should ultimately be evaluated and taught. When thinking about specific skills, you want to understand that efficiency is very important in assent procedures that we're going to be talking about in a moment. And so you want to assess prerequisites for some of the more efficient arrangements for assent. So for example, if a client has developed speaker and listener verbal behavior skills, they are going to be able to engage in a lot more assent opportunities and do so much more efficiently because their ability to engage in complex communication will enable some of that stuff. However, if they don't have those skills, they can still definitely be involved with different assent arrangements and choices. So other skills you want to think about is observational learning skills, simple and complex discrimination skills, And a lot of very common behavior analytic skill and language assessments can help clinicians ultimately evaluate those skills. Thinking about those skills, again, they directly relate to procedures. And so we need to also understand the types of procedures that are available. One, or the more common or the standard assessment arrangement, is ultimately providing a client with a spoken or written description of a proposed procedure and asking if they'd be willing to participate in those procedures, right? And ultimately given the opportunity to withdraw their consent or their assent at any point in the process. Clearly, this procedure requires advanced communicative skills on the client's repertoire and therefore may not be relevant to a lot of the clients that behavior analysts work with. And so when thinking about, okay, so if they can't engage in complex communication, how can we still ultimately arrange assent for them? Was one of the very first research projects I undertook in this area. And I ultimately looked to see what other experts had been doing to navigate this particular issue. And I stumbled upon the American Academy of Pediatrics Committee on Bioethics, who'd been doing this research for decades, looking at how to facilitate involvement in the therapeutic decisions, regardless of communication skill, but like looking at that process to understand what are the essential components of it. And they had 4 critical components of assent that ultimately must be achieved to consider something assent, but has flexibility in terms of how it can be actually implemented. And so I took those 4 critical components and I translated those into behavior analytic terms and concepts as a way to help guide behavior analysts in that process. So the 4 critical components translated from the American Academy of Pediatrics is acquaint the client with relevant treatment options, establish discriminative stimuli for treatment options, test confirm stimulus control of those discriminative stimuli, and arrange choice. And I'll break each of those down. So starting with the acquainting the client with the relevant treatment options. As we previously discussed, it's very, very important for consent and assent for there to be an informed component of it, meaning there has to be clarity as to what they're assenting or consenting to. So the goal with this particular component of an assent arrangement is to help a client learn the critical components of the relevant procedures. Ideally, you want to do this through as little direct exposure as possible. So one way to help an individual learn what a procedure is going to be like is to expose them to that procedure. That's less than ideal because that is ultimately exposing them to something without them agreeing to do it. So if you can't avoid it, you should avoid it. Sometimes verbal descriptions are sufficient, right? We don't have to go do it. I can just tell you what it is, and then you can agree to do it if you have those skills. Other times, modeling might be an effective tool. So instead of telling you about it, I might show you, I might model with another client or a confederate or something like that. And if they have the skills to benefit from those types of arrangement, then that's great. If they don't, then perhaps temporary initial direct exposure to the procedures and then giving them the opportunity to choose if they want to continue might be the best route. Within that process, there needs to be discriminative stimuli established that allows the client to signal whether they're willing to engage in the response or not. So this could be a verbal statement. It could be the client saying, yeah, I'll go do that. Or it can be contrived stimuli. It might be an icon that they touch or a room that they go into or something that they don't have to engage in advanced communication to ultimately communicate. Once you have those stimuli established, you need to test to make sure that they are actually relevant to the actual choice that is being made. So you have to avoid arbitrary responses. I had a client that just repeatedly said yes, yes, yes over and over again. That's literally the only vocal behavior he engaged in was just saying yes, yes, yes. And his treatment team, this wasn't behavior analyst, but his treatment team ultimately used him saying yes, yes, yes to give the guys that they were getting him involved in treatment decisions. They say, hey, do you want to vacuum? You want to do this? You want to do that? And he would always just say yes to everything. And they were just saying, yeah, he agrees to do everything. That's a problem, right? He doesn't have true stimulus control over that response. So you might consider evaluating tact accuracy as a way of determining whether that response is in fact accurate. You might also evaluate correspondence between assent choice and behaviors within the procedure. So if a client engages in a response indicating they're willing to engage in the procedure, and then the moment the procedure begins, they start resisting it, that might be an indication that they didn't really assent to it. And so you need to kind of look at the specific way of making the choice in that process to make sure it is in fact accurate. Once you have that established, you should arrange an opportunity for the client to engage in assent via a choice procedure. This can be arranged verbally if they have those skills, right? You can say, hey, you want to do this or do you not want to do this? But it can also be arranged via concurrent chains or concurrent operants assessment. So ways where they can select icons or they can just directly interact with procedures can be adaptive ways of doing it if a client doesn't have advanced communication skills. Ultimately, the key here when arranging the choice is that there needs to be at least two options available, and one of those options has to be a control. So it has to be the opportunity to dissent. It's not just choosing between two different procedures like a DRA procedure and a DRO procedure. There has to be the choice of saying, I'm not engaging in any of those procedures. And I'll explain why as we talk about the importance of fair choice within assent arrangements. So it's essential that choice to participate or not participate in a procedure be free of coercion and undue influences. Right. We don't want to be forcing choices or any particular choice option on a client. So when we think about that importance of creating a context that is free of coercion and undue influences, some people may interpret that to mean that choice has to be a free, or assent has to be a free choice, emphasis on free. However, the idea that assent or frankly anything else has to be a free choice kind of conflicts with determinism and some other concepts that are kind of central to behavior analysis. So when thinking about this issue, I think Diane Bannerman said it best, which is from a behavior analytic perspective, options in life are valued, but choice is anything but free, which I think is a succinct way of saying we greatly value choice. We think it's incredibly important. We want to maximize it. But whether we consider it being completely free of influence or not doesn't really align with determinism. So this idea that it has to be completely free of any influence can be a little confusing. So instead of trying to arrange a quote unquote free choice where a client would have no influence over their choice at all, which again, from a radical behaviorist perspective, I can't really conceptualize. The key here with a fair choice is not eliminating all influence, which I don't believe is possible, and instead is focused on establishing a fair choice where I eliminate coercion and undue influences. To avoid some of coercive and undue influences, it's important to avoid forced choices, which is when a choice ultimately is given the appearance of being free, but it's constricting the choice, right? So it's saying, hey, do you want to engage in a DRA or a DRO? That could be considered a constricted choice. That might be a completely fine, appropriate choice in many contexts, but you couldn't consider that to be assent because there's no opportunity for them to not engage in either. And while DRAs and DROs might be very useful and practical and helpful for many, many clients, it is possible that a client may not want to engage in either of those, and being constricted in their choice to engage one of those would be, in that case, considered coercive, right? The example I often give is, would you rather, uh, engage in I don't know, a long, boring lecture that you're going to fall asleep during, or would you rather, hear a baby scream for 2 hours straight? Like, I don't want to do either one of those things. And so being constricted to those two choices really isn't a fair or appropriate choice. It's unrepresentative of what they would actually choose. You also want to avoid lopsided contingencies. So lopsided contingencies involve coercive contingencies like threatening ultimatums that are kind of unrealistic or disproportionate to an option of a choice. So for example, I work with a lot of teachers who want to get the child that they're teaching involved with group activities, and the kids engaging in challenging behavior during it or refusing to do it. And so the teachers will often say, hey, you can engage in this group activity or you can sit in detention for the rest of the day, right? So it's, you can engage in a potentially aversive activity for, let's say, 15 minutes, or you can sit in detention for 8 hours. Like, that's a pretty lopsided contingency. The alternative to say that, okay, you can engage in this procedure, you can engage in this group activity, or choose not to, and regardless of what you choose, the outcome for you will be the same, may not be appropriate or realistic either. So for example, if I'm working with that teacher and saying, okay, how do we want to potentially see if the client will opt into going into that group contingency, I might say, well, if they want to choose to sit at their desk, they can sit at their desk, and while they're at their desk, they can look at, their academic books or whatever it might be. Or if they engage in the group activity, maybe they'll have access to social reinforcers. The other kids are over there playing. Maybe there'll be some movement-based reinforcers if they're, moving around, having a good time. Maybe after, if the client engaged in that group activity, maybe they'll get a little bit of extra time to do something they enjoy doing after that group activity. And so you would look at those, you go, those are not equated outcomes. They're not the same, right? Frankly, engaging in the group activity is a better option, likely, when you look at those contingencies. So we're not saying that they are completely free or that they are completely without influence. However, the contingencies are what I think most people would consider to be ecologically valid or appropriate or socially acceptable, right? That yes, one of the choices does appear to have sort of better outcomes, but it's not disproportionate, it's not coercive, it's not aversive, it's just supporting a behavior that is ultimately what is in the best interest of the client. And so when looking at these contingencies and how one may be different from the other, the important thing is not to create quote unquote free choices, as I don't see how that's possible. It's creating choices that are socially acceptable, and to do so, you should involve, the treatment team and other folks to give feedback on that process.
Cody, could I
Yes,
deliver the second keyword before you continue?
of course.
Folks, the second keyword for your CU is fair. The second keyword for your CU is fair. Thank you.
The next layer of consideration is understanding that assent, you need to understand the opportunities to select assent. So understand that assent is a dynamic process, that assent should be arranged as an ongoing process rather than something that is done at the start of a therapeutic relationship. So in behavior analysis, assent is not as simple as the kid shows up at the clinic or the school or wherever and or at home and you go, hey, are you willing to work with me? They indicate yes, and then you have assent for anything you want to do after that. It needs to be more ongoing than that and really should be focused on the big changes to procedures and individual procedures. Like, hey, will you do this with me? Are you willing to do that with me? The problem with that is the scope and purpose of therapeutic services can vary greatly in what we do. And we're making therapeutic decisions constantly, right? All day long, every day, a BCBA is making all sorts of choices. And so we have to be careful that we don't run into the paradox of choice, which is ultimately the idea that giving too many choices to a client may have counter therapeutic effects and ultimately negative effects on the client who gets overwhelmed with the choices, right? And the same way, and this is research that's been looked at not just with individuals with intellectual disabilities, but any of us are susceptible to being overwhelmed with choice, and so we have to be careful not to do that to our clients. Assessing procedures before they're implemented is an important piece, but the complication with that is I might need to make changes from moment to moment in the procedures I'm implementing. And if that's the case, if I'm constantly having to adapt my procedures to fit the client's needs, and the client assented to something that was kind of different than what we're doing, does that really count as assent? And so to navigate some of those complications, it's important to, first of all, select a socially valid number and focus of assent. So it's not going to be realistic that you're able to get assent on every single thing you ever do, right? So you want to kind of focus on the important and salient components of the treatment and to reevaluate and check in on the assent as much as possible. One way to do that efficiently once you've obtained assent is to do so through informal assent procedures. And so the last thing that I'll talk about is the process of informally assessing assent and what that looks like. So everything we've talked about so far has been focused on the formal assessment of assent. So it's directly measuring variables of interest, right, through all of those procedures we talked about, right? So to formally assess assent, there needs to be a choice, there needs to be a fair choice, and there needs all of those individual components need to be focused on treatment decisions. But you can also utilize what are called informal assessment of assent procedures, which is looking at behaviors that may be relevant to the variable of interest, in this case, assent, and it can provide us a little bit of information about this. The the example I like to give here when understanding the difference between formal and informal assessment procedures is when you look at like reinforcer assessments versus preference assessments. Strictly speaking, preference assessments do not actually formally evaluate reinforcers. However, they do evaluate preferences, which tend to have a correlation to reinforcers. And so we can utilize similar procedures as a way of informing whether a client's assenting to something or not. An important component in understanding informal assessment procedures is understanding assent withdrawal, which I've talked about a few different times as being important, which is ultimately that in any assent context, the client needs to be given the opportunity to withdraw their assent at any given time. And so there needs to be a continuous evaluation and monitoring of assent withdrawal. When you're monitoring assent withdrawal, it's important to understand that a lack of withdrawal should not be taken as affirmation that a client is continually assenting to procedures. there are many, many reasons that an individual may not engage in active assent withdrawal. And for that reason, essentially any prominent group that's focused on assent in terms of, providing guidelines says be very, very careful not to assume assent withdrawal is indicating assent. The other piece is that our clients may often engage in ambiguous assent withdrawal behavior. So they might indicate they want to end a procedure not by clearly communicating that, by engaging in other behaviors. And so, like I had a consultation one time where the client, when he was kind of over a procedure, he would rock back in his chair, which to his treatment team signaled that he is done, right? And typically, if they didn't immediately honor that he wanted to be done with the procedure, he would start engaging in challenging behavior a few moments later. And so it was amazing that his treatment team was able to identify that pattern and identify that behavior. But what I recommended to them was, okay, take that response, honor that response, but also work with the client to learn to communicate that more effectively. Because when you start trying to train staff, if you've got turnover with your staff or whatever it might be, it's going to be difficult for everyone to connect and go, okay, when he leans back, that means he's done. If he touched an icon or something that made it more clear, it's going to be something that will generalize a lot easier. The other thing you've got to think about within the idea of informal assessment is assent adjacent behaviors. So assent adjacent behaviors are things that appear related to assent but are not clear indications of assent. So examples would be indices of happiness or the client engaging in an activity or something like that. While those components are really, really important and useful in their own right, and we'll talk about those, right, because those are ways of involving clients in therapeutic decisions, they are not necessarily an indication of assent. So assent adjacent behaviors are that sort of wheel of strategies of involving clients in therapeutic decisions is not necessarily an indication of assent. There are a lot of reasons that someone might be happy with something, but not necessarily agreeing to do it, which you can equate to if you've ever used an app and then found out that the app company was selling your data without you knowing. Had they just looked at your behavior while engaging in the app, they go, yeah, they're smiling, they're laughing, they're having fun on this app. And so therefore they're consenting to anything we're doing related to that. It's not quite as clear as that, right? Because there has to be that informed component of assent. And so just because someone's happy doesn't mean they're assenting. To summarize, assent is multifaceted, it's nuanced, and there's a lot of critical components to arranging assent. It's also one very specific part in the process of a client getting involved with therapeutic decisions. And so what I often recommend or ask folks to consider is when they're thinking about assent and consent and the importance of involving assent and consent in therapeutic decision making, it's to prioritize assent and consent, but to remember that it's part of a larger process. That ultimately, I think the goal of behavior analytic intervention and service is to involve clients in therapeutic decisions as much as possible. One way of doing that is maximizing opportunities of assent, but there should be other things that you aim to do, right? You should be thinking about social validity. You should be thinking about client involvement and treatment planning. You should be thinking about how to create as many choice opportunities as possible within treatment. You should be thinking about indicating responses. You should be thinking about indices of happiness. Because all of those are critical in maximizing client involvement in therapeutic decisions. And if we want to help clients gain as much independence and autonomy as possible, we have to present them opportunities to practice those skills. Right. I always, think back to my childhood and some of the first big decisions I remember making. Like I remember going to a gas station with my family and my mom giving me like $1 and saying, "Hey, you can go in and pick out, the candy you want or soda that you want within the gas station," right? And I remember thinking about that decision, right? Like, how can I maximize the value of this dollar? What candy do I want to get? What soda do I want to get? And how that being my first sort of financial decision led 30 plus years later to me practicing more and more financial decisions over time until I'm making very, very big financial decisions, right? I'm choosing my retirement package. I'm purchasing a car. I'm buying a house. All of those things, all of those indications of autonomy and independence that I now get to enjoy as an adult was built on practice opportunities where I got to make choice within my small financial decisions or other ways of practicing independence and autonomy. I did not go from 0 to 100, right? In one jump. I had to practice that over a lifetime. And so I think it's our responsibility as clinicians and therapists to make sure we're giving our clients opportunities to practice those skills, as well as doing it to inform our own therapy along the way. And so my call to action here is to clearly delineate which aspects of client involvement therapeutic decisions you're focusing on, right? Focus on all of them, delineate them, clearly label them as the separate strategies, and ultimately incorporate them all in practice as much as possible to be as supportive to our clients as possible. So with that, I will put my email address up here if you have any questions or comments. I'd love to hear them. You can put them in the chat, and then you can always email me any follow-up if you don't get a chance to ask them now.
Thank you. Thank you very much, Cody. That is a brilliant talk, and you've raised many, many valuable points. I really love the quotes, by the way. Some of them are really powerful. People have been quite active in the chat, and I think they've enjoyed it. I can see already the thank yous coming in. Folks, the last keyword for the CU is candy. The last keyword for the CU is candy. And I will repost the CU link to a form. Make sure that you have that sitting in your browser so you can add the info that you need. In the meantime, type away your questions. I'm giving you a bit of time. I know you always need a bit of time to articulate your questions. We've got a few minutes left. There's also a feedback form. Please do give us some feedback. If you click on that link and have that also sitting in your browser, we would appreciate your feedback. I've got a question for you, Cody. Does the US have anything similar to the Mental Capacity Act processes as we have in the United Kingdom? I would assume so. I think you have legal guidance about how to assess for mental capacity and to get informed consent and so on, right? Do I remember correctly?
We do have it's kind of state by state and how that works a little bit, but there are general guidelines on how you might assess quote unquote capacity. The complication is there's a lot of ambiguity in those instructions. I don't know what it's like for you guys, but like for example, for the federal guidelines for research, the stipulations for if someone has quote unquote capacity to engage in assent is something along the lines of it'll say like if they're above 7 years old, if they I think it's like literally if they have the ability to make the decision, which is like that's like what does that mean to make the decision? You know what I mean? So
Mm.
it's just a little complicated. And I've worked with clients that have extreme communication difficulties that that certainly have the ability to make meaningful decisions that I've seen them make, right? And I've seen the opposite. I've seen clients that are very talkative that have difficulty times making decisions. And so it's like difficult to say, well, if they're communicative, well, then they should be able to do it versus not. And so I think these adapted ways of thinking about assent, where it's not just can they communicate or not, it is ultimately, can you establish these parameters? Can you provide some information about what that would look like? Can you create a response for them? Can you arrange a fair choice? That's I think a way of doing it that'll open up the opportunity to make those decisions to many more people than you would if you were just to follow those sort of state or federal guidelines.
Yeah, I agree. I find the same in the UK. I mean, in the UK, the caveat is that if you look carefully at the wording, you need to have a reason to think someone doesn't have capacity to go in and assess it.
Yeah.
So if I casually think everybody has capacity, I'm like, oh, I don't have a good reason to think they don't. I can be, I can be very naughty and cheeky about it. So yeah, I agree. It's not very well defined, is it? People are saying very interesting session. Thank you. Your article was also very helpful. Someone says, I love the simple visual with all the different components. I've got a comment. It says, these issues are more legally based when you're supporting adults. Good point. It becomes easier to skip the complexity of unsed when you're teaching small children who aren't their own guardian by default. Yes, very good point indeed. Parental consent kind of trumps everything. You're like, I've got parental consent. It's, I can do whatever I want. Very good point. Someone says, thanks, Cody, inspiring talk. Really interesting. Yes, I can send the CEU link again. Here you go. Let me scroll through any other comments I might have missed. Excellent presentation, such a great topic to disseminate. Someone said earlier, you're so incredible in your assessment. Okay, folks, I can tell you're fans of Cody. So I think we've established that quite a lot with all the comments, Cody. All right. Cody, thank you very much again. I don't see any other pressing questions. Guys, keep an eye out for Cody's publication and work. Cody's also hosting a really enjoyable podcast that has recently changed name as well, right, Cody? Could you briefly talk to us about that podcast?
Yeah, so quickly, for the last few years, I've been doing a podcast called Behavior Analysis and Practice, which is focused on the journal Behavior Analysis and Practice. Recent in partnership with ABAI, we've pivoted our podcast efforts to cover all of ABAI's journals instead of just the one. And so the new podcast is called All Things Behavior. It's available on all the major podcast platforms. To search for All Things Behavior. We just started a few weeks ago. We've got, I think, 5 episodes out now. So if you're interested in that kind of thing, subscribe and like it.
Brilliant. All right. I will be sure to check it out, and I'm sure the folks here will as well. Okay, thank you very much, Cody. Folks, this is going to be uploaded on YouTube. Keep an eye out for your CEU. Make sure you fill out your forms. I've got about 40 days to respond to you, so don't wait for them, within the next week or so. I'll take a bit of time if that's okay. And I will see if I can also send the slides along the CEUs if Cody is happy to share those with us. All right, folks, thank you very much. Thanks again, Cody, and I will see you all soon.
Thanks.
Bye, guys.